Thank you, Doug, and thank you, Betty and Miguel. I'm going to talk about disability after stem cell transplantation in children. And I want to focus on a little bit on the things that are similar between children and adults, but really highlight some important differences. And I think you noticed that Miguel already mentioned that in general, survival after transplantation is better in children than in adults. And there are probably two major reasons for this. The first is that the children generally, though not always, come to us with much less in the way of prior morbidities. So we don't have any children coming who've been smoking for 30 years or drink a lot of alcohol generally. But also the children have an intact thymus, a gland that helps your T cells recover and reconstitute. So in general, immune reconstitution is better. And the infections that Miguel talked about are less prevalent as our children recover more quickly. Having said that, we do recognize that for children, transplant can come at a cost, just as it does with adults. And Betty has been talking to us about chronic conditions. Chronic conditions are important in children just as they are in adults. And this comes from a report that compared the number of chronic conditions in transplant survivors, and these are people who'd received transplantation as children, compared with those receiving non-transplant therapies. And remember that those receiving non-transplant therapies typically have less aggressive or easier to treat disease. So on the left are all chronic conditions, on the right are the more severe conditions. And I remind you that chronic conditions covers a wide range of different problems. It can be as simple as hypertension requiring treatment or an extremely severe limitation due to cerebral injury, for example. But I show you these data really to emphasize the point that if you look at the bottom axis, this is age in years, people transplanted as a child, the risk of accumulating chronic health conditions continues throughout life. Now, this is true for you and I as well. You know, getting older, we all accumulate deficiencies or injuries to our bodies. But this is clearly accelerated even in people transplanted as children. So this is cure with a cost. Similarly, mortality continues to be increased as time extends from transplantation. And you can see this report starts at 2 years after transplant, and you can see still quite a big kick in mortality over in the period immediately after transplant, but then increasing mortality with increasing age, which again is true of all of us, but is increased markedly in those who've undergone transplant. This figure also shows you something very important, though. This is the curve from prior to 1990, 1990 to 1999, and 2000 to 2010. And you can see significant improvements. Look at the change in the curve of the blue line down here compared to the earlier curve. So there are important improvements ongoing, and I think it's vital that we bear that in mind. We are making very significant progress, and I venture to suggest that the progress in children has been particularly notable. So I mentioned to you that I would focus on what's different about children, and I really think this table is one of the most important things I want to tell you. And the first thing I want to tell you is that just as Betty told us, graft versus host disease is an extremely important cause of disability and morbidity in children. Probably the leading indicator if you're looking at a case quickly, you want to get a clue what's going on, there's chronic graft versus host disease. It's reasonable to expect that there will likely be increased disability, decreased ability to fight infections, and that while both of those abnormalities are likely to improve, it may take time and sometimes a number of years for it to go away. So I won't say more about graft versus host disease because everything that Betty told you about adults is in general applicable to children also. So let's think a little bit about additional problems that we might look for in children. So next thing is orthopedic issues. And obviously orthopedic issues matter in adults in terms of disability. We've talked about frailty, we can think about arthritis, joint damage, things that happen to regular people as they get older. In children, we expect generally their bones and joints to be healthy. A very important complication that we see is avascular necrosis of bone. And this is death of a small area of the bone, typically related to exposure to steroids, and that is typically related to graft versus host disease. And for reasons that are only moderately understood, this is a particular problem in teenagers and is more of a problem in girls than in boys. This can lead to need for joint replacement or significant pain and limitation of mobility. This is extremely painful when it occurs in areas that are not amenable to joint replacement. There are some primary diseases that we transplant for, and we'll talk about those a little more, where orthopedic complications are typical. Reduced bone density is common in our children, and we monitor for it. And we heard earlier about frailty. And frailty is a concept that we don't usually think about with children. We imagine them to be strong, vigorous, and full of energy. But frailty does occur in children as well as in adults. And just as in adults, it's associated with increased risk of poor outcomes. It's associated with increased disability and poor outcomes in children. Though the use of the term frailty is really only just coming to the fore in pediatrics, and I think it's an important area of ongoing investigation. The impact of critical illness on disability can be very important. During a transplant, there can be episodes of infection or other complications which require transfer to the ICU. And these admissions can be associated with reduced functioning and increased challenges. In children, we are aware that the brain development is not complete. Remember, the human brain, it doesn't really complete its development until the age of about 25 years. Our children with long illnesses have time out of their education, so they lose straightforward knowledge, but they also lose socialization and the development that's necessary to progress from childhood through to adulthood. Behavioral issues become more prominent, and the impairment of social development is something that's rarely talked about, but is really important. It's very difficult to go back to school as a teenager, be new kid in class, you look a little different because you've been ill, you're behind developmentally, and you're socially awkward because you've just been in hospital and around adults for a couple of years. And these are the less seen issues that make it hard for our children to progress in school and in employment. The diagnosis that our children are being transplanted for is extremely important. Mary mentioned earlier, the majority of adult transplants are performed for malignancy. In children, we transplant a significant number of children for malignancy, but there is a range of fairly complex genetic disorders that are, and other non-malignant disorders that are transplanted for, that they are themselves associated with cognitive deficits and orthopedic complications. And lastly, the use of radiation is generally avoided to the extent that we can in pediatrics, because as I say, brain development is not complete and radiation can retard the completion of that development. But there is a very clear survival benefit to the use of radiation in children with acute lymphoblastic leukemia, and therefore it is used. And these children, as they get older, require careful monitoring. They will often need additional help in education with issues with focus, attention, and some other specific cognitive function. So these are additional things to think about when you're thinking about whether a child has a disability and whether that is likely to be reversible. I mentioned that diagnoses are important, and I just wanted to flag for you some diagnoses that are associated with a high burden of likely disability or expected disability, so that they might be drawn to your attention. So the first two things I want to draw to your attention are the leukodystrophies, and that's typically adrenoleukodystrophy, metachromatic leukodystrophy, or Krabbe's disease, and mucopolysaccharidosis type 1, also called Hurler's syndrome. And these two disorders are dementias of childhood. And typically we don't think about dementia in children, but these are dementias because the children achieve milestones and then lose those abilities progressively over time, just as one would see in an 80-year-old with Alzheimer's. So children that have been able to speak in sentences regress to using 2 or 3 word phrases, and then if untreated will eventually lose the ability to speak entirely. These disorders respond to transplant because the transplant replaces an enzyme that is missing. And the goal of treating these disorders is to treat them early before significant cognitive decline has occurred. However, the diseases are a little unpredictable, and particularly if diagnosed late, may worsen during transplant, and patients may be left with important disabilities that are likely to be fixed. So keep an eye out for these diagnoses: leukodystrophies, mucopolysaccharidoses. Patients with sickle cell disease who come to transplant typically have a severe phenotype, otherwise the risks of transplantation would not be justified. So these patients do come to us with significant prior morbidities, almost reminiscent of a much older person. They may have prior lung damage, cardiac damage, they may have had a stroke or multiple strokes, and they can get the avascular necrosis of bone that I spoke about from the sickle cell disease, and without any need for any steroids to worsen it. So this is, again, a diagnosis to look out for, likely to be associated with disability. Patients with Fanconi anemia are susceptible to frailty due to metabolic abnormalities, and they have a very, very high rate with an odds ratio in the thousands of subsequent squamous cell carcinoma. Similarly, patients with dyskeratosis congenita, another marrow failure syndrome, will have progressive lung fibrosis and liver fibrosis as they get older. Lastly, patients with brain tumors may undergo multiple autologous transplants to substitute for the need for very high radiation doses in childhood. But these patients will have typically had a large resection of a brain tumor and may also have cognitive impairment, motor impairment, and growth impairment. So be very aware of the diagnosis. An important move towards reducing these disabilities is the introduction of newborn screening, now active in every state of the United States, though the diseases that are screened for can vary. So babies are now screened for some leukodystrophies, sickle cell, mucopolysaccharidosis 1, amongst other diseases. This is an important reduction in disability due to earlier referral for transplant. The earlier these children are referred, the better their outcomes are. And we've seen a major change in the outcomes for children with mucopolysaccharidosis in the last 5 years. Gene therapy strategies, if they are successful, may reduce disability in these populations when used early. This remains to be seen, however. Sickle cell gene therapy is making important progress. There is a helpful gene therapy for adrenoleukodystrophy, but other disorders are yet to enter the field of gene therapy. And we can talk about that more in the discussion if people would like. I mentioned cognitive difficulties and access to appropriate educational services. These are extremely important. We talked about cognitive impairment due to underlying diagnosis and radiation and missed education. I mentioned also infection, the encephalitis, sepsis with hypotension, and vascular injury can occur. Stroke can occur even in small children. Thrombotic microangiopathy can cause increased issues. Access to educational services is an important problem for our children. The immune compromise commonly prevents early return to school, and as Miguel pointed out, particularly in COVID time. And if any of you have been at home with your children will know remote learning is not great, especially if you've got challenges and if you have social difficulties and learning difficulties. Children forget how to learn, how to remain focused, how to listen to a teacher. It's a skill that we usually learn in preschool, is how to keep your bottom on the chair. The children forget, and it needs to be relearned. And some children with complex medical needs are deemed too daunting for particular schools, with good reason, and it's hard for those children to re-enter normal education. Having said this, the majority of children, most survivors, will do well in terms of cognitive difficulties and educational attainment. This is a study by Wu et al. That looked at eligible survivors transplanted aged less than 21 and more than a year from transplant, using a specific neurocognitive function quality of life set of surveys generated by the Childhood Cancer Survivor Study, a cohort study of over 30,000 childhood cancer survivors that's been followed for over 30 years. This included 199 participants, so about half of whom had been treated for acute leukemia, mostly allogeneic transplants. And the median age at the time of survey was 37.8 years. So these are adults surviving a median of 25 years after transplant. On the neurocognitive questionnaire, between 18.9 and 32.5% of survivors reported impairments in various domains. And this compares with an expected rate of about 10% in the general population, so increased. But when you looked at the quality of life report, the survivors reported a very similar result to the normal population. And this refers back to the previous comment that even people are resilient and adapt, and even with measurable deficits, people will compensate and have a valuable life. The risk factors that were independently associated with poor scores were hearing issues, and this is extremely important and something that needs to be followed, a history of stroke or seizure, which indicates brain damage, and sleep disturbances. We've had the conversation about why would anybody undergo this therapy when it sounds terrible. And of course, we're focusing on what's difficult about it, not on what's good about it. But we need to put these side effects in the context of the original disease. And a good example is sickle cell disease. Stroke and cognitive decline are hallmarks of sickle cell disease, and it becomes, while it can often be not that big a deal in a child under 10, by the time people enter their early 20s, it's a significantly damaging disease. And natural history predicts a progressive loss of 1 IQ point per year from the disease. So think about that when you're 20 years old. You've lost 20 IQ points. That's a significant issue. So the sickle cell unrelated transplant trial looked prospectively at both cognition and MRI imaging after transplantation. The study included 13 participants. Their median age was about 12. 7 had overt strokes, which is part of sickle cell prior to transplant. 1 had elevated transcranial Doppler velocity, which is the early indication of a susceptibility to stroke. The average IQ was stable. In this population where we do expect a steady decline in IQ, it was 90.9 at baseline and 91 after transplant. And the performance IQs was stable also. So here is a disease where one can potentially halt the progressive decline associated with the disease. I mentioned bone health. Bone density is reduced and fragility fractures are common after pediatric transplant. Swager et al. Are about to report on 237 pediatric transplant recipients from a single center. 10% of those had evidence of at least one fragility fracture, and this means a fracture in the setting of reduced bone density on imaging. And this can be quite alarming. Children will fall off the sofa and break their arm or break their ankle. And in the patients with at least one fragility fracture, 72% sustained spine fractures. These are usually compression fractures of the vertebrae, which are extremely painful for the children. Median time to fracture was about 6 months after transplant. And again, the incidence was significantly higher in those with graft-versus-host disease. The cumulative steroid exposure was significantly associated with fracture in patients. So patients with graft-versus-host disease are typically treated with steroids, so they get this worsening complication and fragility. And pain, limited mobility, and need for casting, poor healing, all limit the time that the children can get back into school, get back to normal life, and lengthen disability. A proportion of the patients who have genetic disorders that involve the bone, particularly mucopolysaccharidoses, will need orthopedic surgery after transplant. And this image shows a progressive kyphosis in a patient with mucopolysaccharidosis. And patients with mucopolysaccharidosis need repeated bone surgeries because the transplant delivers enzyme to well-vascularized areas. The bone gets poor enzyme delivery, and there is continuation of the mucopolysaccharidosis process at those sites. And doing something like putting a rod in the back of a child like this is problematic because that child is going to grow. So you either have to devise your metal rods so that they have an inbuilt capacity to grow, or you have to do repeated surgeries over time. I mentioned earlier that avascular necrosis is particularly disabling in adolescents, needing joint replacements and causing severe pain. We also need to remember the caregivers who have associated disabilities of their own in addition to the need of taking care of their children. Children recovering from transplant need a very high level of care. They need administration of medication, observation for infection, physical therapy at home or the hospital, multiple doctor visits. They usually can't. The care cannot be shared with school, daycare, babysitters, and multiple other family members unless they're educated in the care of this ill child. All of these things limit the ability of the primary caregivers to work, and particularly in children with graft-versus-host disease and late complications of primary disease. Caregivers are typically stressed and traumatized by the experience of transplant, and often financially challenged by being unable to work. And remember, I've talked to you about a lot of genetic disorders. The important thing to remember about genetic disorders is that families will have more than one affected child. And we have families in whom 3 or 4 children might have a disease that needs transplantation, and that can be an absolutely overwhelming burden for any one family. So support for caregivers is essential for recovery and maintenance of the family unit.
Stella, can I ask you to just cover this slide, because this is really important about the subsequent employment, and then we want to make sure we have enough time for our audience, please.
Yes.
Thank you.
So I will finish by saying that employment subsequent to transplantation, and pointing out that disability can persist for many years. In this study, a transplant group, including 59 adults, transplanted in childhood, a median of 17 years earlier, were compared with 296 individuals randomly selected from the population. 54%, only half of the long-term survivors were working part or full-time, and 19% were on sick leave or disability. So it's 19% compared with 6% less than a very significant difference compared to the general population. So this is an important long-term problem. And Doug, I'll hang it up there.